So standard of care treatment for soft tissue sarcomas is generally different depending on which histology you're using. There are some generalities, of course. When we look specifically at a uterine leiomyosarcoma, the options for her for first-line therapy become an adriamycin-based therapy. So whether or not we want to combine adriamycin with ifosfamide, combine it with dacarbazine, or are we looking to combine it with novel therapeutics and targeted agents like olaratumab? The other options for a patient like this would be, are we looking towards gemcitabine and taxotere? However, we would anticipate that the toxicity profile of a combination gemcitabine and taxotere will be slightly worse than that of adriamycin as a single agent. So with the availability of olaratumab on the market, one has to really question about where do we sequence this, what do we combine it with, and what will essentially happen with patients moving forward. The anticipation based on the overwhelmingly impressive data from the phase 1b and phase 2 is that given the survival advantage of the combination of adriamycin with olaratumab, that would then become the first-line therapy for patients. And so perhaps in the general treatment approach, one is moving ifosfamide off of the initial treatment regimen, perhaps removing single-agent adriamycin out of the armamentarium of which we're using for treatments of patients, and we're probably sequencing gemcitabine and taxotere as a second-line agent and maintaining adriamycin or doxorubicin-based combination therapy as a first-line agent. So the clinical trial of the phase 1b and 2, which reviewed patients with metastatic or unresectable disease, showed that the addition of olaratumab to doxorubicin did increase the toxicity profile slightly. It didn't really increase the grade 3 or 4 toxicity dramatically, and so that's reassuring. But what it was able to do is profoundly impact overall survival for patients and extend survival by almost a year versus patients who didn't receive the combination therapy. So the phase 2 data for olaratumab and doxorubicin was very impressive because it was one of the first studies that actually used more doxorubicin than what traditionally is used and what has been used in prior phase 3 clinical trials of doxorubicin with a second agent. And so while most people have used 6 cycles at 75 milligrams per meter squared of doxorubicin, here is a trial that now expanded that and used 8 cycles of therapy at 75 milligrams per meter squared. What is unique in this situation is that there was the addition of Zinacart for the last 4 cycles, which would have given some cardioprotectant, which is essentially the concern that people have, is that more doxorubicin will essentially affect the heart in a negative way. So what always becomes important to think about when new drug combinations come to market or new drugs come to market is, what do you do with all those patients who have previously been treated that didn't have the availability of this drug for first-line therapy if we are very excited about now using this as first-line therapy? And so I do think it is very important to look at our patients that have previously been treated. It becomes very easy. If a patient had previous treatment with gemcitabine and taxotere or another combination that is not doxorubicin-based, well then we could use this as a second-line agent or a third-line agent as a combination of doxorubicin and olaratumab. The harder thing is for patients who have had a number of cycles of doxorubicin, they may have maxed out their lifetime dose of it, and perhaps they're not eligible for the addition of olaratumab to any other treatment, and therefore perhaps one could look at this as a single agent for those patients, depending on what the labeling by the FDA is. The other issue here is going to be if someone only had 2 cycles of adriamycin or doxorubicin and then progressed on that, do you want to cycle it back in, the doxorubicin, but this time add the olaratumab to see if the patient could derive the benefit of olaratumab and perhaps then using it over 6 cycles instead of 8 cycles?